Okay, good afternoon and welcome back to this session. I am very pleased to introduce this team, which is leading change from the front line of care. So we are going to have 3 presentations, and unfortunately time is very short, but we will try to do our best and also offer you the possibility to intervene with questions, or we hope also your experience. So we are going to have the presentation and, of course, the possibility for you to ask questions. Every presenter will introduce themselves. In this case, there are 2 people, and then at the end, you are welcome with questions. So we start. Please welcome Annette and you.
Thank you. Right, good afternoon, everybody. My name is Jan Davies, and I'm one of the co-directors of our 1,000 Lives Plus programme in Wales, and also head of our clinical governance unit at the Welsh Assembly Government. And I'm also pleased to introduce my colleague, Annette Bartley, who's a member of our Welsh Faculty for Healthcare Improvement in Wales. So we're going to spend the next half an hour talking to you about some work that we've been doing in Wales in terms of our attempts to transform the front line of care, and how we've been working with our colleagues across the globe to take this forward. So just for those of you who aren't familiar with Wales, this is what our country looks like. This bit down here, our long border, joins with England, and that in itself has some challenges for us in terms of managing quite a big border. We're a very small country, but we've got very bold aspirations in terms of improving the healthcare for our population, which is just under 3 million in size. We've got devolved responsibility for the NHS in Wales with our own government, the Welsh Assembly Government. Staff, around 72,000 whole-time equivalent staff, and that is now organised through 7 local health boards, which are integrated organisations providing primary, secondary care, community and mental health care, some aspects of specialist services in some of those. In addition, we've got a couple of specialist trusts, but for the provision of care in the main, it's through our 7 local health boards, and that's the work we're going to describe for you today. So the background to this work, like most of the countries here, we've embarked on a patient safety campaign, a national campaign, the 1,000 Lives campaign. This was launched in April 2008 and ran for a period of 2 years until 2010. We set ourselves some very bold aims and attempted during that time to save an additional 1,000 lives and avoid up to 50,000 episodes of harm in Welsh healthcare. You'll see from the list there, there's a number of familiar areas which most of you will have probably had some involvement in. And so those were tried and tested areas, the leadership, infections and so forth. But then at the bottom in red, this is what we want to really focus on today, was the work that we took forward in terms of transforming care at the bedside, or TCAB. And this we took forward as a sort of development initiative during the period of the 2-year campaign. The reason we did this was obviously we hadn't used this methodology before in Wales, and we were really, really fortunate that Annette had just come back from spending a year out at IHI's during a fellowship and had worked on that there. So we're absolutely fortunate to be able to capitalise on Annette's experience and try this out in Wales. Does it move in? So, where are we now? Just to give you a brief view, so 2 years on, we're now into our successor programme, the 1,000 Lives Plus, which has become one of our national programmes in Wales, aligned to our strategic framework, alongside a number of other national programmes. And it draws on the work that we did and learnt from during the 1,000 Lives campaign, and other work that we've done in what we call our intelligent targets, which have been clinically focused targets, far more focused on trying to improve patient outcomes. So what have we done during this time to sort of move the agenda on? Well, I think what we learned from the 1,000 Lives campaign was that change is possible. The things that we'd accepted for so long in terms of hospital-acquired pressure ulcers, healthcare infections and so forth, we now know that it's possible not to be able to tolerate those things. So our First Minister set us, and the public service as a whole, the challenge of adopt best practice or justify why not. And that's really what the focus of our programme now is based on. The learning as we try and test new ideas, and where we can see that they can work in one place, we've got a challenge really to make sure that's spread to every corner of Wales. This has gone forward now in terms of, so the 1,000 Lives programme launched in May this year, and underpinning that now from April this year for the next year, we've moved into making sure this is part of our transformation agenda in Wales and set out in our annual quality framework the things that we now want every corner of Wales to adopt. So trying to move away from a system focused on targets to one which is driven by improvement, underpinned by a set of new values for the NHS in Wales, which puts quality and safety at the top of all that we do, and a focus on reducing waste, harm and variation in our system. So it's about mainstreaming this work, really. It's making it the way that we do business around here and not going back to the old ways of doing things. Oops, sorry. So before we continue, just want you to take a couple of minutes to sort of talk to the person next to you and ask yourselves, what are your thoughts really about basic frontline care? What's good about it in your experience, what's not so good, and what do you feel needs to change? So if you just do that for a couple of minutes, and we'll come back to you then, and Annette will then go into the detail of the transforming care work.
The interactive bit. You got your watch.
She doesn't have just the clock, does she?
That's good.
She's next, isn't it?
This is good.
Yeah.
Oh, the guy's here. Afghanistan.
All right. Do you want to do that now?
We just started. How long we got? Let's see. Give me a poke.
Right, well, I'm sure we could talk all day about what improvements we want to see, but hopefully from the short conversations you've just been having, I think we'll all agree that wherever we work and whatever we do, we can always seek to improve. So I'm now going to hand over to Annette, and she's going to tell you a lot more in detail about our Transforming Care programme and the background to it.
Thanks, Jan. Good afternoon. This is the participation bit. We thought we'd warm you up. Hello. So delighted to be here with Jan, sharing the work that we've actually done in Wales. So just to talk a little bit more about transforming care at the bedside and what that actually is. Now, I actually was so fortunate to go out to IHI to do a Health Foundation IHI fellowship. And whilst one of my aims when I went out to Boston and spent a year there was actually to find a way of how to truly engage frontline staff in quality improvement and patient safety. And in my previous experience, I'd worked in improvement for a number of years. What I found was often that quality and safety initiatives come in through the top of an organisation, very top down, a group of elite people doing this work and taking it to the frontline staff. And the frontline staff, by the time it gets down to them, it's heavy. It feels heavy. And it feels like it's being done to them. So what I wanted was to find a way that we could really re-energise and refocus frontline staff in seeing quality and patient safety as their improvement, as their responsibility. Because after all, they're the people who can make the difference tomorrow. If they change the way they work, if they work with patients, listen to patients, patient safety and quality could rise up very quickly. So we need to really keep that focus at the front line. So when I got to the States, I came across this program, Transforming Care at the Bedside, and it had been launched in 2003 by the Robert Wood Johnson Foundation, a charitable foundation, in collaboration with the Institute for Healthcare Improvement. And it was designed to engage leaders at every level in the organisation, not just the top, the middle, every single level in the organisation, in trying to improve the quality and safety of patient care. At the time, it focused very much on acute medical and surgical wards, but that programme has gone on to look to transform across the system. But it was also about increasing the retention and vitality of nurses. And at the time, American nurses were leaving the profession. And I think, it's very similar across the whole world. And it was about how can we retain the vitality. When we come into the profession, whether it's as a nurse or doctor, we're full of energy and enthusiasm for really making a difference. And somewhere along the line, that gets beaten out of us. So how could we get that energy back in the frontline staff to engage them in it and improve patient care in co-partnership with patients? So they don't just feel that things are done unto them, that they actually truly feel partners in care. And how could we improve the effectiveness, not just of the nursing profession, but the entire care team? So the programme itself was based on IHI's idealised design process, and it was about, people know what they should be doing. There's buckets of guidelines, there's shelves full of dusty policies. The what is out there, the evidence is out there. But it's the how that people find difficult, and how do we make it reliable, and how do we build safe and reliable care for every patient every time. And IHI's idealised process had a number of aspects to it, but some of the main ones were about linking the initiative into the strategic plan of your organisation. Don't see it as a project, something that will come and go. It's a great framework for building quality. We used a process called the snorkel, and I'll give more information if people want to snorkel after. But it's a way of generating ideas from frontline staff. And really, frontline staff are the ones who've got those ideas. They're closest to patients. As the saying goes, they're where the rubber hits the road, and it's really important that we listen to them. And by listening to them and freeing up so that they can actually take the ideas and test them using the model for improvement, it actually brought such energy to those frontline staff. We actually looked at how can we take best practices and actually get them into practice, but not just get them there reliably. And we built this learning community across the States. Now I think a couple of hundred organisations have been involved in IHI's programme. And it's about testing and implementing new ideas. Now, the important thing was that, it was based on evidence. There was lots of experience, practice out there that we already knew was good. So it was about taking all these good things, putting them into a framework, and actually coming up with some great outcomes, not only for patients, but for staff. Now, when we actually went back to Wales, I came back to Wales with my backpack full of ideas, and I found Jan, and we did some talking about how could we transform frontline care in Wales. And this was the reality in practice in Wales. And I'm not sure if you can all see that very closely. But on the right-hand side, the patient's saying, "You don't look so good, shall I call the nurse?" And on the left-hand side, it is the nurse saying, "I am the nurse." And this was our reality, and I'm sure many of you identify with this. Very busy, very complex patient care, heavy workloads, reduced minimum levels of staff, a really difficult place to be. So we really could see that this could benefit frontline staff. So as Jan said, it began as a development initiative. We used the IHI model in terms of starting small. At the time, our chief nurse thought it was a fabulous framework and said, let's do this everywhere. But we said, no, this was an American model. It was devised for a system that's very different to the care system in Wales, predominantly private healthcare system. And we need to see whether or not that actually works. And Americans are naturally enthusiastic individuals, so the term vitality was a great term for them. But when I took that word back to Wales, it didn't, vitality, that's quite a different word. But we kept that word because that was something we felt we needed to bring back to frontline care. We took a slightly different approach. We focused on the patient, not just interventions and outcomes, we focused on the experience of care. because patients can have a great outcome but a poor experience, and we wanted to be able to balance those two things. We took a bit broader approach than a nursing approach. Whilst nurses led the work, we actually had strong multidisciplinary team representation. And we started with 3 pilot sites. 2 of them had 2 wards, and then 1 pilot site chose to focus solely on pressure ulcers. And we had slightly more focused aims. I always say if you can't name them on one hand, it's difficult to remember. So we had 5, and here they are. We wanted to increase the amount of time nurses spent in direct and value-added patient care that was of value to patients, to 70%. We wanted to reduce hospital pressure ulcers to 0, but it was a little bit too ambitious at the time. So we compromised and came up with a 50% reduction goal, and we also looked at in-hospital falls of 50%. And the final 2 pieces were about happy staff and happy patients, because if we don't have happy patients, we don't have happy staff. There's a real correlation, and the evidence supports it, to show that we need to focus on both. So those were our lofty goals. Now, I know you can't see the detail on the driver diagram up here, but this driver diagram sort of set out the things that the primary drivers that we would be focusing on. And there were 5. The first one was about transformational leadership, about changing mindsets, not just saying to people, you will lead, getting them to really think differently about, what does this mean for me as a ward sister? This is about, it's not going to happen on my shift. And you know, earlier in the sessions, people talked about, you've got to be safe to work here or you don't work here at all. It's that kind of cultural shift, and it starts with the individual. We also looked at value-added care. We wanted to create safer, more efficient environments, freeing up nurses' time so they could spend it on things that added value for patients. The safety and reliability was all about reducing those outcomes, and we just focused on those 2, falls and pressure ulcers. Patient-centeredness, absolutely the linchpin to it all, and finally the teamwork and vitality. We also learnt from industry. We took off pilot teams to the Airbus factory where they make the wings for the Boeing 707s or whatever they are. And there was so much that the teams actually learnt from that visit. You know, when we walked into their Lean Academy, there was a person on the door, and as you opened, as you opened the doors, you could actually, it said you were entering a person-centered zone. So, you know, their ethic, the whole way they talked about transformation and improvement, there was so much that we could take back to practice. So there they are at the Airbus factory in Chester. Now, when we actually looked at the end of the pilot was 2 years, we actually started to see we were getting some really good results. Not only were the units that were involved in the programme increasing time in care, and some of them went from 40% up to 60%, which wasn't quite the lofty goal, but very close to it. And since then, they've actually reached that 70% and gone past it. So we could see that was gradually happening as nurses understood where they were wasting their time and where they could redirect their time towards patient care. We saw a significant reduction in units in falls, 36% reduction, and that was the best results we had. But the biggest results that we had were around the pressure ulcers, and we had just amazing, some world-class results. And one of the units that focused solely on pressure ulcers, all of the sites reached the 50% reduction and surpassed it. But one site actually has just gone this April, 3 years with only 1 pressure ulcer, and that was a grade 2. So some significant improvement, and that was spread across a 93 ward or unit system, 4-hospital system. And their average, they used to have about 20 pressure ulcers on average a month, maybe more. And now they've actually gone down to less than 4, predominantly 1 or 2. So their incidence rate has gone from something like 14 to 22% variation to less than 1%. So huge change. And a real understanding at frontline level what that meant. Now the safety cross is that green calendar that you can see in front of you. And every day, nurses would proactively check patient's skin, and if a patient had any break or redness, it was noted on the safety calendar as a red day. So their aim was simple: we want a green cross. We don't want any pressure ulcers on this ward. And it really motivated the staff, and they used a simple process called a skin bundle to actually build some reliability in that care. And they very quickly got 95% compliance with risk assessment. They linked that to a process of an intervention, and they got the results. So some outstanding work which is now being shared internationally, and they're actually getting recognition for that, which is phenomenal. So many things that we learned from this pilot, and we actually built a national learning community. These 5 units came together at national events. They shared tools, they shared techniques, they shared energy, enthusiasm, and we really started to build a great network which still continues today. Now we're going to give you a little snippet into a video where we're going to show you, the teams themselves actually devised this video at the end of the pilot phase. So here we are, over to the teams from Betsy Cadwallader in North Wales.
Hospital Radio, it's Andy Hayes here in the hot seat playing the hits. First of all, we start with a request for Doris and the Girls song number 6.
What's the matter? Oh, and it's such an awful morning. We're lucky to be having this break now. It's my first break all day. Listen, this has been my day so bad.
Transforming care at the bedside. It helps nurses spend more time with patients, such as we've introduced intentional rounding.
Sensational, tell what did you say?
Intentional rounding.
You know, we've probably always done it, gone round to check on the patients, but this is slightly different, because we make sure it happens every 2 hours by keeping the log. And we've got a kind of script to work from to make sure we do the same thing every time. We especially round on patients at risk, for example, of falls or skin breakdown. The process ideally involves a nurse and a healthcare support worker checking on toilet needs, inspection of skin, observing the immediate environment for safety and comfort. Some patients don't necessarily need the full check, just a comfort check. More importantly, it gives patients an opportunity to communicate any needs or concerns during this time and reassurance that they'll be checked on again. The tests have gone really well. It's doing what we've always done, but with a real framework, and are now showing early signs of a reduction in hospital-acquired pressure ulcers and inpatient falls. The feedback we've had from both staff and patients has been very positive, and I know the Director of Nursing is keen to spread intentional rounding to all the wards. We all groaned when we thought we'd have to measure everything, but the safety cross is so simple and gives us an instant idea of the number of days between falls and pressure ulcer cases. TCAB is all about empowering the frontline staff, and in some areas the healthcare support worker or housekeeper have become real champions. On Ward 11, housekeeper Pippa updates it on a daily basis. The data is converted every month into a run chart, so we can see over time our improvements. The Falls pilot ward
I have to cut it there, I'm afraid, but hopefully that gives you a flavour of how engaged our frontline staff and bringing the housekeeper into the work as well, that it really was a team effort. So where are we now? Well, this is our mantra really in the 1,000 Lives Plus programme. If you can do it for 1, you can do it for 10. If you can do it for 10, you can do it for 100. If you can do it for 100, you can do it for 1,000. And that's where we aim for during our campaign. but now with 1,000 Lives Plus, our aim is to do it for everyone in Wales. So transforming care is now something that's happening everywhere. There's been a real pull for it. We had a huge pressure while we were sort of doing the testing phase because everybody wanted to do it across Wales. So we really had to sort of hold it back a bit. But it's now become a framework that's in place and is being implemented everywhere in every corner of Wales. And just to sort of end briefly, we'll just give you a flavour of where that's at. So it's from board to ward to home. You'll see that the bedside bit is gone. It's now transforming care because we know this is a framework we can use anywhere, in any unit, in any place. So just to hand back to Annette, and she'll just sum up with where we're finishing.
As Jan said, it began in acute medicine and surgical units, but now we've had pulls from A&E want to use it. We've started transforming theatres, transforming maternity. We have staff at the front who are actually working on transforming maternity services. So using the same framework, and endoscopy, community hospitals, and we want to really look at how we can work with patients and family and use that framework in their own homes to avoid pressure ulcers and falls. So really exciting future. And as you can see there, we've moved from that pilot to transforming the acute setting into the community. And what we'd like to see is that in order to sustain results in those units, that we have some accreditation that's dependent on keeping results in a good place. So before we close, just one final slide. And I think, changing hearts and minds is one of the most important pieces about transformation. So I'll leave you with this quote from Saint-Exupéry in The Little Prince. And it says that if you want to build a ship, do not gather men together and assign tasks. Instead, teach them the longing for the wide and endless sea. And I think transforming care has given us that option to bring a model that worked well in the States to allow us to adapt it and adopt it and to make a difference for patients and staff. Thank you.
Thank you very much, Annette and Janet. We have learned so much, I think, and now we move from Wales to England, and we are going to listen to Liz's word, and at the end we are going to share and ask questions, because we have 2 more presentations in our journey. Welcome, Liz, please.
I think that last slide from Wales is going to actually set my presentation up really well. So my name's Liz Ward. I'm from England. I work for the National Health Service, which obviously is a public public-owned organisation. I work for the institute that do work around improvement. But as I was sat there getting really nervous about standing up and speaking, and I saw the nurse running around, I've got 21 years experience of nursing, and it did actually calm me back down, realising that what I'm about to do now was nothing compared to a day's work when I used to work as a nurse. So it has calmed me. You'll be glad to hear. So high impact actions then, and how to mobilise thousands of nurses and midwives for change, is around using commitments and social movements and campaign thinking with underpinning improvement science. So what I want to quickly do is to give you how high impact actions mobilises nurses and midwives, and how that it inspired these nurses and midwives that I've certainly met through going through this piece of work to bring around positive impact on cost and quality. But I'm going to share some very practical examples how the nurses and midwives have done that, and actually give you a bit of insight of what propelled me for the 9 months that I worked on this piece of work, and what inspired me as well during this piece of work. So the development of the high impact actions is actually underpinned by something that another piece of work that we're doing in NHS England called Energizing for Excellence, and this is around using social movements and social thinking and campaign thinking, and this is a call to action for nurses and midwives in NHS England, and there's lots of copies down here, but please don't get up yet, wait till we finish speaking, and you're more than welcome to take this away. If there's none left, there's some on our stand as well. well. So the high impact actions are actually the call to action then for nurses, and we started that call to action in September 2009. And what we did, we asked nurses and midwives in NHS England to actually submit papers where they thought that they had brought around cost and quality improvement. And in a 2 weeks period, we actually had over 600 submissions, and they were from all the healthcare settings that we have, from hospital care to community care, to nursing homes, to care from nurses that provide care in prisons. We had a whole range of selections of submissions, and then what we had the task to do with this 600 submission is actually decide what our actions, what our call for actions were going to be. And we did that with around 80 senior nurses and frontline nurses, and actually decided and launched 8 of the high impact actions in October. In November, our chief nurse actually told what these actions were and what the call to action was about. And then in November through to June of last year, we decided that we needed to do some supportive material and documentation to help support nurses to get energised around the piece of work. And that's where I got involved, working at the NHS Institute for Innovation Improvement. So this document, this piece of work, we actually called the Essential Collection, and the reason we did that is because it was a collection of narratives, of stories, of how frontline nurses had made a difference to quality and to cost. And some of these stories and these narratives are focusing on the efficiency and the effectiveness of care that they were delivering, but also what these narratives do is harvest the energy for change, and that's what the really exciting thing was that I started to get really excited about. But underpinning them narratives and them stories all the time is that we were very careful to balance that we needed to demonstrate and practically help nurses and give them some improvement tools and link to other initiatives of work that the nurses might have been doing. And what we found is it was quite a crowded pitch out there, and there was lots of initiatives and work that nurses were doing, and what we wanted to do is to actually bring all of them initiatives and then pieces of work together and call them the Essential Collection. Also in the Essential Collection as well, we have a section around measurements, the improvement science, and we have quite good return on investment calculations where we demonstrated where some of the organisations that we'd visited had either a cost neutral impact, or they'd actually had quite a significant return on investment as well. So why did we decide then, when we were doing this piece of work and we did the call for action, that this should be led from the front line? And I think previous presentations spoke around how sometimes change can feel very top down, and that definitely does sometimes feel like that in the nursing arena. And the guiding principles behind this piece of work is that the frontline nurses are actually the best placed people to lead the quality and cost improvements. And there's a myth out there often that nurses or clinicians even don't actually understand the implications of better care actually means lower cost. But I actually found that myth, it blew that myth away, that actually is unsubstantive. It isn't there. In NHS England, the nurses are one of the single largest workforces, and if you can collectively mobilise this workforce and call them to action on particular areas of health care, then we're a force to be reckoned with, really. And it's a personal, and I found this every day, that it's a personal and moral responsibility to engage in this piece of work, because it fits with our core values of why we wanted to come into the service and do the work that we did. And as I've said, poor quality is very costly. The piece of work was very focused on eliminating inconsistencies. All over England there's a phenomenal amount of improvement happening, but people are not sharing that improvement. So, if your ward or your neighbours or your neighbouring organisation is making improvement work, why aren't you? And why aren't you going out and finding out what that organisation, what that other hospital is, or what even that other ward is doing? Why aren't you finding out and actually acting upon that? And the opportunity is absolutely enormous, and there's a real sense within this economic climate that we have to do something or be done too, and that's very clear. So the high impact actions then, there's 8 of them, and the first one is Your Skin Matters. Staying safe, preventing falls, keeping nourished, getting better, promoting normal birth, important choices when the time comes to die, fit and well to care, ready to go, no delays, and then last but definitely not least, protection from infection and looking at urinary tract infections. Now, any nurses within the audience, and I'm sure there is, will think, well, they're not new. They're not new actions. They're not new things that nurses have looked at before. But what we found through the 600 submissions, that nurses are still frustrated and are still trying to work on these 8 actions because we're not getting it right. And I just want to pause there for a minute because I think that's really, really important. We're not getting it right. So to mobilise then, so when we started this piece of work, what we realised very quickly is that we need then stories and then narratives that people can emotionally connect with. We need that shared vision and that passion to be the best, and I think that call to action demonstrated that. We need that leadership that develops the capacity of others, and I don't mean the top-down leadership. We have some phenomenal and fantastic nurses that work on the front line that equally are some of the best leaders that we've got that work in NHS England, and we need to give them the capabilities and the capacity to drive a piece of work like this forward. We need to connect through personal relationships. We need to find those at the centre of the networks, and events and conferences like today are the opportunity to be able to do that. And we need to get the energy and the commitment from these frontline nurses, because people that are motivated and are doing things that are meaningful are, the common beliefs and values falls into that. So we started with a campaign. So we had a campaign called I Am Committed, and what that meant is that nurses throughout NHS England could sign up to the campaign to say they were committed to do work around the eight high impact actions, and we had a phenomenal response to this. So you could either do it web-based or you could do it via postcard, and we have thousands and thousands of nurses that have signed up to be committed onto this piece of work. So what I want to do now is just to give you some very practical examples of some of the changes, and what's significant about the 3 that I've chosen, that they're very different. Now, the first one is around Your Skin Matters, and this was a piece of work that had been done by community nursing services that actually looked at 8 nursing homes and the referrals that they were getting around pressure ulcers. So obviously it falls into Your Skin Matters. And what they found, that there was massive trends around lateness and inappropriate of referrals, and these referrals were the root causes of quite high and significant admissions to their local hospital with pressure ulcers. And what they did is they put a business case together to appoint a full-time tissue viability nurse to actually work with the 8 nursing homes in their locality, in their region, in their area. And what that did is that resulted in building up relationships with the nursing homes and better education. They actually introduced a wound care formulary as well, and the ownership of that nursing homes around pressure ulcers actually heightened and increased. So rather than a fallback position of actually phoning the community nurses, they were very empowered into doing pieces of preventative work themselves. And it actually had a massive, significant return on investment. And what we found with that piece of work for over a 12-month period is that every pound that organisation spent, they got a return on investment of £51.56. And obviously that's the cost benefit, but there was a massive amount of quality benefit and safety benefit as well for the patients. So the next example I want to very briefly tell you about is an orthopaedic hospital that actually managed to maintain a zero rate of catheter-acquired urinary tract infections for over a year, and they fell from that rate fell from 32%. They're obviously an orthopaedic hospital, so they're a very specialised hospital, so they had quite short stay patients, and they had a very good track record of MRSA and C. diff, which meant there was a perception within that organisation that they didn't have an infection control problem. Actually, they had a very small infection control team. They weren't satisfied with that. Some of the ward staff had been reporting to the infection control team some concerns about an increase in catheter-acquired urinary tract infections. And what they did is they went out and looked if they had got a problem. And what they found was the national average was about 73%, and they were currently at a 32%. So what this resulted in is in a campaign, what they called Think Link. Now, basic improvement methodology, they talked about using patients as a power and as a resource to disseminate the message around why it was important to obviously clean your catheters and have good catheter care. They used simple hand hygiene. They introduced an educational program around non-touch technique. They communicated by using this symbol of the links. They communicated very well across the organisation, which had a massive effect that they managed to reduce their incident rate from 32% to 0%. So very, very different sort of approach than the last case study that I shared with you. Now, the other one is something around staying safe and preventing falls, and we had an acute hospital within NHS England that had one ward where the ward sister had actually thought and researched around dementia and something called sundowning, when patients tend to fall at the end of the day at an evening time at 5 o'clock in the evening. She researched this, the sundowning effect, and actually designed something called a Tiptree cafe style toolkit, which is very, very basic. It was having a red tablecloth, and for the dementia patients having familiar items, and they were coins or dusters or purses or playing cards or dominoes for the men, and they were able to have some positive distractions for the patients at this period of sundowning period, when dementia patients can start to wander and get quite agitated because it's the end of the day and they feel like they need to go somewhere, and that had a massive effect on their falls rate, because consequently the patients that are wandering have got more prevalence of falling. So this toolkit that this one ward sister had used within her organisation had actually spread across the organisation, and then when we saw the positive effects that we're having, we decided to include that narrative and that story within the High Impact Actions essential collection document, because it just demonstrates that small innovative ideas can actually have a large impact. So how do we mobilise nurses and midwives for change then? So through this piece of work and collectively going up and down the UK, what became really, really obvious to me and the colleagues that I worked with, that to mobilise nurses and for them to feel motivated and committed and engaged, there was three key themes that came out of all of the narratives in the story. And I think the first one, that nurses felt very engaged if they were self-directed. So it wasn't the top-down approach, that they were allowed to flourish and have ideas and be self-directed in that approach. The next one was mastery, so the challenge. So I think most nurses, enjoy a challenge, not every day, like the video that we saw. But there's a real personal, good feeling about having a bad day and achieving something at the end of that day. Most people, or some people, do sports and play musical instruments. That's not insensitised. You don't, nobody pays you to do that. It's because you have this will and this desire. to be a master of it and to be challenged by that. And I think that's very true for nursing as well. And they have to have a purpose. A lot of the stories that we told, we actually asked nurses why they wanted to be a nurse at the beginning before they started talking about the change and the impact they had. And the very purpose of why they came into nursing was very current throughout the story that they were telling us around their impact and their change. So that is what we hope that the Essential Collection brings, is the stories, the personal stories, and the stories of change as well. So I said that I wanted to share with you what inspired me throughout this story. Now, I visited lots of organisations whilst I was doing this work and personally collected these stories and these narratives. And I think, during this 9 months where I was very tired, I think at one point I came across this story which really inspired me and actually, constantly reminded me why I came into nursing and equally why I am now working within an improvement role. And there was a story of a community team that were doing some works around reducing supplements, prescriptions of supplements. And this one team told me about this lady, and she was an 83-year-old lady, and her name was Jessie. And she'd been discharged from hospital after being diagnosed of having a hiatus hernia. And on discharge, this lady lived alone and was discharged to her own home. And translated, she had a hiatus hernia into I can no longer eat, I can only drink fluids. So for 2 years, this lady had been discharged from hospital, actually believing that she couldn't eat and all she could do was drink fluids, and she'd constantly been prescribed for the 2 years period supplements, prescribed by her general practice. And it wasn't till this community organisation decided to look at supplements that they actually stumbled across Jessie, this 82-year-old lady who had not eaten for 2 years, and actually questioned and got to her narrative and got to her story to understand why she wasn't eating anymore. And it was a misunderstanding on her part, but this lady had become very isolated. She didn't eat anymore in her community, and she'd often gone to a local, what we call day centres, where she ate with other people, and she was no longer doing that, embarrassed by not being able to eat. So after only a 3-month period and lots of visits from the dietetics team and the GP, they managed to wean her off the supplements with her agreement and actually build her up. So there's a success to this story, that after the 2 years, the lady had actually started to eat a normal diet, and she was now allowed to eat in community and socialise with her family, and no longer felt embarrassed about going out and eating with other people. And I think, actually using narratives and stories is really, really compelling, because that piece of work, that improvement piece of work, actually brought around £650,000 of improvements in just 5 months. But I think what the narrative and the story and connecting with that lady's values, what that actually teaches us is that we ought to act, and actually inspires us to act as well. So I think from my experience of getting involved and mobilising nurses and midwives to get involved in change and in improvement, yes, we need the improvement sciences, but we need to balance that with the narrative and the story and connect people that are working on improvement to actually understand what their core values are as well. So I'm just going to do one more slide, and I just want to, just have you think for a minute, is the importance of leadership in these very tough economic climate and economic times, that enabling others to achieve purpose in the face of uncertainty is our responsibility as leaders within health and social care. And that's it. Thank you very much. So if you do actually want to find anything else out, we'll stand 22. Thank you.
Thank you so much, Liz. Very interesting. Thank you to your colleague for your experience. And now, people, we just moved to Afghanistan. Now another story, another experience to teach us something more. So, welcome.
Good afternoon, ladies and gentlemen. I know my presentation is the third presentation, and you would hate me if I take more than the allocated time. My name is Mirwais, and I am working as Chief of Party for the USAID-funded Healthcare Improvement Project. My presentation is not speaking about e-health or statistical significance or 95% confidence interval. I am coming from a country where women are still using donkey as the transportation mode when they are delivering, when they would like to go to a clinic. So the slides that I have for you are some small changes, but we are sure that it will give us a great result in Afghanistan that I would like to introduce. That's a brief outline of my presentation. You can see a public hospital on the top and a private hospital below. We are working with both public and private hospital as a project. This is a brief country profile. Country has about 25 million population. Maternity is still one of the highest in the world. 1,600 women die in every 100,000 live births. Infant mortality is 129. We have come a long way. In 2001, 2002, this figure was 160, 150. But fortunately, in the last few years, we were able to reduce this to 129. And under 5 mortality is 191, and you can see other figures in the slide. Oops. This is the goal of the Healthcare Improvement Project in Afghanistan. We are working in 6 provinces. Initially, we started in 3 provinces. The focus is maternal and newborn care. And the overall goal for the country is to improve quality and outcomes of healthcare by adapting and applying modern method of quality improvement. And the coverage is about 5 million, which makes 1/5 of the country's population. This is the package of the high impact interventions that we have prioritized, that we have chosen to work with in Afghanistan. You can see it. We are working at the community level, at the basic package of health services level, where we have basic health centers, comprehensive health centers, district hospitals, and comprehensive those facilities, and also health posts at the community level. And tertiary hospitals where patients are referred from different parts of the country to those tertiary hospitals in the areas are also very specific that we are working with. Key results. I would directly go to the results that we have got in less than a year of our work with some of these hospitals, though with some we worked a little bit more than a year. I'm sure most of you know what Partograph can do to a woman if it is used properly in a hospital. Partograph is a form that normally the health provider is using to monitor the delivery. In some of the hospitals that we have been working with, we found that the Partograph utilization is not good. They are not properly monitoring the delivery process. And you can see that with those simple change ideas, with those simple changes on the right side of the presentation, on the right side of the slide, the Partograph utilization rate has significantly increased from the first change to the second, to the third, and to the fourth. Let me give you just an example. The first change was to train people on how to use Partograph, to train providers how to use Partograph, and you see a spike. And then the team, the quality improvement team in the hospital found that one change is not enough. And then the second change was added, which was daily monitoring of Partograph during morning report. When doctors, when physicians, when midwives get together for the morning report, then they would randomly select 20 out of 100, 120 Partographs that were filled and check whether those Partographs were filled based on the criteria or they were not filled. The third change idea was to put Partograph as the second page in the patient file. Normally, patient file has many pages, but it was put at the second page to the patient file. Then the provider will automatically see that when the name and address of the patient is written in the first page. And the fourth change idea was to use, in some of the cases, or I would say in most of the cases where patients are, delivering women are coming to the tertiary hospitals that we have in the capital, they are coming very late that you cannot start filling photograph from the, most of the providers forget to fill photograph from the very first minute. And then, they were focusing on filling their patient files. What we did, or what we jointly decided, what the quality improvement team with the physicians in the hospital decided to give them only photograph for those cases which come late to the hospital, and you can see it has improved the photograph utilization. This slide is about active management of third stage of labor. This is also very important. Giving oxytocin within 1 minute after delivery, which is a uterotonic drug in which avoids or reduces hemorrhage, is extremely important, and we found that was not exercised properly in some of the hospitals that we have been working with. And then some very simple but very important change ideas were introduced. You can see that the provider is pre-filling the syringe with oxytocin and keeping it with her. And that was the first change idea that was introduced. The second change idea was to train staff on the importance of the oxytocin and the active management of the stage of labor itself. And the third change idea was to ask the woman, to train the woman how to do the massage for herself. The delivering woman after delivery, uterine massage is one of the components of active management of third stage of labor. And you can see that how significantly it has improved the adherence to the standards of active management of the third stage of labor. And you can also see in this slide, I don't want to move to the next one. One of the change idea was to ask the attendant to help the baby soon after the delivery, then in order to enable the provider to give oxytocin within 1 minute. Otherwise, the provider, the midwife, would be busy with the mother or with the baby, and she won't be able to give oxytocin within 1 minute, which is extremely important. But with the help of the attendant, then she would be able to give oxytocin within 1 minute and do the active management of third stage of labor. This is another slide about neonatal resuscitation. Asphyxia is a big problem in Afghanistan, as it is in many other countries. Many newborn deaths are due to asphyxia. Unfortunately, the system, the information collections management system that we have in Afghanistan is still not capable of catching all those incidents in hospitals. But in the hospitals that we work with, we found it's very high. And the change ideas that were introduced was training the first-line providers, and also installation of intercom system. The unit, the department where the neonatologists were sitting was far from the department where women were delivering. So the change idea was to install the intercom system, then the provider would be able to call the neonatologist as soon as there is a problem. And you can see that there hasn't been a big improvement. We did not have in some of these hospitals the equipment necessary for neonatal resuscitation, and now we are in the process of procuring and providing those equipment to these hospitals. 1389, I'm sorry, this is not changed to the Western calendar, it's 2010. And the next change idea, this slide speaks about breastfeeding. Immediate breastfeeding is extremely important for the baby. What would happen in one of our hospitals, mother will be taken to a different ward soon after delivery, and the baby would be taken to a different ward. Despite of that hospital being named as baby-friendly hospital, but they were not giving the baby milk, or the baby was not breastfed within 1 hour after delivery. With very small changes that you can see on the right side, transfer of mothers with the baby to the same ward, and asking the attendant to help if the mother is a complicated case in order to breastfeed the baby. You can see that from 0%, very quickly, without spending any additional dollar, we were able to take to improve the situation to about 70%. And that specific hospital that I just mentioned, it reached to above 90%, which is big. There was hospital, there were equipment, there was staff, but immediate breastfeeding was not happening. And simply with the simple change in processes, we were able to change the situation, and we were able to have 95% of the children, the babies, breastfed. This slide is about postnatal monitoring. Postnatal monitoring is also important. The policy or the rules say that mother should stay for 6 hours in the hospital. Then the mother is monitored half an hour, 1 hour, after 2, 3, a number of times the mother is monitored. Normally, they would stay for 3 or 4 hours, but most of them would not stay until 6 hours. In order to improve the situation, a protocol was introduced to the provider to do the postnatal monitoring. And the second change idea was to delay the BCG vaccine for babies in order to be able to have the woman, the mother, in the hospital until the postnatal monitoring period is completed. But we had a balancing measure to see whether this change idea would make some babies miss the BCG vaccine, and we found that it did not, make the babies miss a BCG vaccine. And the third change idea was to transfer the patient file with the patient to the ward or to the department where the delivered woman was referred. Before that, it was not happening. Mother was going to one place, and the file was in a different place. What we did, we just changed the process, and the providers were asked to take the file with the patient wherever she goes. This is what we are doing at the community level. We are trying to work with CHWs, with community health workers, to improve their skills and their knowledge on specific topics. For instance, here on the left side, you can see there is a monthly meeting of CHWs in one of the health facilities. You know, all Afghanistan is not this well off. This is a northern province called Balkh, which is well off, much better province in terms of resources that they have than other provinces in the country. Other provinces do not have a good room for their CHWs to meet, or they don't have electricity and fans to run for them. And on the right side, you can see that there is a simulation going on of a counseling, trying to improve the counseling skills of community health workers. Still in Afghanistan, 80% of women are delivering in communities at their homes. Only above 19% of women are coming to the health facilities. Focus on community is very important in order to have those women referred to the health facility, have those women informed about the danger signs that they would face during pregnancy, and also inform them, prepare them, work with them to, when the time comes, they access the nearest health facility for help. And this is, you can see, with the work that was done, with the support that was provided to CHWs, the adherence or compliance with ANC, PNC standards significantly increased in those health facilities or in those communities. Now, the way that we were able to achieve, these were only some of the examples of many achievements that we had in last 1.5 years or 1 year. And the methodology that was used is the IHI methodology, model for improvement. What are we trying to accomplish? And every step we try to set an aim for us, and we try to identify measurements to help us understand whether we are going to the right direction or we are not going. And it also helped us to identify potential change ideas and test those change ideas. We started working with, the methodology suggests that we work in a small scale. Within the facility, we have quality improvement teams that work together to improve quality of healthcare. You can see different health facilities have their own QI teams. They work in their own health facilities. They come together after a certain period of time, and in a learning session, they learn from each other. They exchange their experiences, and they are looking at their data, whether what they did resulted in improvement or it didn't. You would not believe 1 year ago when I first joined healthcare improvement project, I was in a learning session. There were midwives from different parts of the country. Every one of them was saying, oh yeah, we are doing partograph, we are using partograph, we are doing active management of third stage of labor, we are doing that, and we are doing this. Suddenly among them there was a midwife who stood up and very bravely said that, let's be honest, we are not doing it properly. We are doing it. We are using partograph, but we are filling only the first few sentences, writing the name of the patient, where she came from, and then we do not use the later parts, which are important. And when she stood up, then many others said, that is true, we are not using it properly. And that was a great motivation, not only for me, but for every member of the team to stay supporting them and to help them with the improvement work. That was the work that we have been doing at the very front line, but that kind of work needs to be supported at the national level, at the Ministry of Public Health, and at different levels that directly or indirectly are in support of the frontline providers. We have assisted the Ministry of Public Health of Afghanistan in developing the strategy for improving quality in healthcare in Afghanistan, and fortunately, recently that strategy has been passed by the Consultative Group for Health and Nutrition. And we have been assisting the Ministry of Public Health to establish a structure to implement and oversee the quality work in Afghanistan. We are trying, and we have been trying to partner with organizations working for quality to improve quality. You can see the second picture is the Afghanistan National Public Health Association, that we have been working with them to inform leaders, to educate our seniors at different levels on quality and quality improvement. And we have been trying to spread knowledge on quality and to expose leaders to best practices. An example is we have the Deputy Minister of Health of Afghanistan. Right now she is not in this room, but she is in a different session. She is with us here, and she is participating in this conference. This is the brief structure of the support for the first line providers. You can see on the top the Ministry of Public Health, the unit for quality, which has been established in the Ministry of Public Health, and that unit is connected, or the vision is to be connected with the focal points for quality in provinces. We have 34 provinces, and we have 6 people working for the public health office in each province. 1 person would be the focal point. And then we have quality improvement teams in each health facility and also at the community level. They will be connected, and they will get support from each other as they are working on the quality. Some of the challenges, these are very grassroots challenges. I did not mention some of the challenges that we have at the national level. These are the very low level, low wages, and therefore low commitment, out-of-date, complicated admin procedures, lack of female staff, turnover of staff in implementing NGOs. We have a contracting out mechanism where one NGO take over from another NGO after a certain period of time. Lack of basic needs in some of these health facilities, supplies and equipment. Not matching reporting and monitoring system or simply the health information system with the level that we expanded services in the last couple of years. We have made a great expansion, but we have to work on our measurement system on the data that we get. And finally, security. Security is a big problem for us. I put it at the end, and I hope that one day security will not be on our list. We sometimes enjoy the progress that we make. You can see on the left side of the slide. And sometimes we face problems. On the right side, you can see a village where our colleagues went, and then they faced an accident. You can see there is no road. The infrastructure is in a terrible shape, but people are committed. They are going, and they are trying to improve quality of healthcare. I think that's all that I had for you today. I hope you enjoyed it. Thank you.
Thank you very much. I think we are very rich today. May I kindly ask you to share with a friend or the people next to you one idea you bring home from this presentation, one idea you want to share with us, because we all teach or learn, and a question you want to ask to our speaker who are available for the questions. So please share very quickly, 2 minutes, one idea you bring home, one idea you want to share, and a question for our speaker. 2 minutes, and the speaker are here. You have to come here. You have microphone? You have to come there, because I cannot, it does not work. Is someone going with the microphone from the staff, please? Otherwise, I have to look for. Okay, I come with this. If someone wants to ask a question, you have to here. So when you have one question, one idea you bring home is. We don't have staff helping, so I come with the microphone. Please introduce yourself.
My name is Margaret from the Netherlands. I'm working on the National Patient Safety Program. We have a website, and we try to do the sharing of the good ideas and of the stories. So one of the ideas I take home is your stories of nurses. And I think together with the story on the first morning of Maureen, where she said about the New York Times, who has this kind of stories on their website, I thought we can do that on our website. That's very good. Thank you very much.
I am sure you all have some idea you bring home, you share with us, and question for our speakers. Yes, please.
My question is to the last speaker, Mirwais. My name is Hugh Rogers. I work in England for the NHS Institute for Innovation and Improvement. We who've been working in improvement for a long time have been adopting the sort of methods you talk about. I'm very impressed at the progress you've made in such a very short time using actually very similar methods. How's that happened?
I think the team that was responsible for this to do it, they looked at their data daily. They looked that, when they collected data today, it was here. And then when tomorrow they went and they again collected the data, or after a week when they went, they found that the dot was not there, it was up. And that was, I think, the motivation for them, for every one of them, to go again and again and again and work with those frontline providers to improve quality of healthcare. It's not only for the team that I am supervising or I am working with. It's also for the Ministry of Public Health people, for the hospital people, where they have their own whiteboards, where they have these graphs for individual indicators that they have, and then they see that the line moves from one row to another row. I think that's a big motivation for them to achieve that kind of result so far.
Hello. Yeah, it's Bridie Kent here from Deakin University and Eastern Health in Melbourne, Australia. And it's a question for Annette and Jan. I'm just knowing the diversity of the health organisation or the health hospitals in Wales. How have you addressed the issue of communication between the sites, given the fact that when it was in its pilot, you had networking going on? Have you put something in place now to allow that interconnectivity between the sites?
Yeah, if I just start and then Annette can probably add to it as well. As part of our 1,000 Lives of infrastructure, we've got quite a good communications network wrapped around it. So we've got a very, very sort of busy website, has lots of hits, and we have a monthly e-bulletin that goes out to as many frontline staff who want to see it. We've also got a series of learning events both across Wales, and we use a sort of mini collaborative approach in terms of events for particular sort of special topics and so forth. We've had special days on things like the pressure ulcer work. So there's a lot going on. We use also our nurse directors have forums. So there's a whole range of communication mechanisms that we use. But Annette also has developed the learning community, and I'll let her speak about that, particularly on the TCAB work.
Just to talk a little bit about sustainability, we can always set up external learning communities and bring everybody together, but sometimes that can be quite expensive. So we had, obviously a collaborative type approach for the first pilot. And then in the first year following the pilot, we brought all organisations together in a learning community on a regular basis in a collaborative style. But what we've tried to do now is we're moving beyond that, and we're trying to get that collaborative learning within organisations, so they build their own sustainable infrastructures. So instead of looking outside, they actually can, one of the organisations have actually got a transforming care faculty, and they've linked with their university, and they send all their nurse leaders through a programme that teaches them the skills and improvement methodology and the pressure ulcer work, etc. So we're looking to really bring more sustainable change, but we kind of started that, pump primed, as they say. Okay, thank you.
Please share also your ideas for us, because you all have something to share. Not just ask questions, but also what was nice, was something to bring home, and please tell us your experience too, because we all learn from everyone. So in this case, may I ask Liz, how do you do now? Because it's interesting when you start with the change. Okay, everyone is with us. We can try to many new things. But now, after a while, how can you reinvigorate your people?
I think that's a really important question, and very surprised that you've not thought of it, audience. Very disappointed in you. No, I'm only joking. I think sustainability and keeping momentum is really, really important. And I think, the fundamental thing is the ownership of the piece of work. This is a definite call to action for nurses and midwives. It is owned by them, and their networks within, their own networks within where they work within their organisations makes it really, really powerful. I think importantly, and I hope what we did with the high impact actions is recognise all the work that other people have done in other initiatives. We've got initiatives in NHS England called productive ward, which is very similar to the TCAB piece of work, and it's important to recognise that all the time that you're doing great work, share it. And I think that's the most important thing then, the message, you know, tell your story, tell your narrative, tell us what you're doing. And I think that keeps momentum in itself when everybody keeps sharing their ideas and sharing their stories. So, but communication is really key momentum.
Annette, what about you? How do you reinvigorate now your people?
I think it's about releasing the potential at the front line, because there's lots of energy there. And, you know, the snorkel exercise that we do, really that's a tool that we've given, or it was given to us, and we've given it to frontline staff. So if they have an issue, they come up with a snorkel, and they come up with ideas about how they can actually solve that. And, you know, that really frees them to solve their own problems. So I think sometimes you wait for external people to come and tell you how to solve things that you have the answers to. So I think that's been a great tool that we've given to frontline staff, and I think that helps to re-engage, energize and engage them. Thanks.
I have a question, because now you see in this audience too the sharing of what you're doing, or it's obvious we all want it, but it's difficult to organize. So I'm working, as I said, on the National Safety Program in Holland, and we try to do that to enforce the sharing. But please tell me how to do it, because we're not managing very well.
I personally think there's a difference between organising change and mobilising people for change. And I think through what we did with the call to action for their impact actions is actually lots of people on the front line are quite, you know, they get the change fatigue. You know, they hear things over and over again, and I think we have to, I absolutely say that we have to have the improvement science, and we have to have the change management and everything, but you really do need to mobilise people and really get to what their core values are, and I think that's the, you know, that's the message around the stories and the narrative, because we are also very busy, and the frontline staff are really definitely busy, and lots of pressure on them. You have to remind them why they came into the service and what their core values are, and once you connect with that core value, I think that unleashes the energy that unleashes that energy, and you know, percentage of work that people do, there's about 30% of work that you can get out of people just through that commitment and committed with their core values. So yes, organising is right, you need to have a strategic way that you're going to communicate and do that, but equally balance that with the mobilisation and connecting with the people that are working.
Yeah, but I'm sure. Yeah. So if you want to work on change on one side, the way you said, but connecting, and what the other two ladies said is kind of bring back the vitality into the energy, to organise the energy of people. So I'd like to know, you did some sharing, right, with your stories, but it's how do you make people share? So it's not how to make people change, but how to make people share.
Yeah, right. Yeah, I mean, one of the things that we found is that when we started to do this work, there was a real healthy peer competition that came in. People wanted to share things, so it almost became a sort of, you know, a bit of a competition, but then but also it really helped to change the culture. So, for instance, one of our learning sessions, other nurses, when they were hearing about people who'd managed to sort of, you know, almost eliminate pressure ulcers, they couldn't believe it, so they wanted to go back and they wanted to try it. So I think there's no one way to do it, and one of the things that we've used a lot is actually the media, because obviously, you know, we're all members of our community, aren't we? So like I say, we do a lot around communication. So we have monthly columns in our national newspapers. We've had a lot of TV coverage. We've also networked a lot with other countries. So, for instance, we've got really good working going with our colleagues in Denmark on the pressure ulcer work. And in fact, our work in Wales was on the Denmark news a few weeks ago. We're now showing that on our website in Wales and showing our staff in Wales the difference they're making and the international impact it's having. So that there's no one way to do it. We use patient stories a lot. We take patient stories to our board meetings. It's just in your face, and it's making sure that you're telling a good story, people can relate to it, and you share it in every possible way you can think of. So websites, newspapers, meetings. I'm working with colleagues, like from just the last couple of days we've been here, we've spoken to so many people and already want to look at how we can get a sort of virtual network going on the trans-sewing care work. And so just keep at it, really. There's just try every way you can.
Just a couple of practical things to add, really. When we brought people together in a learning community, they were really interactive. So we had a World Cafe where there were cafe tables and people would have topics. So it might be pressure ulcers or falls, and people would sit round and discuss, what are you doing, what am I doing? And they'd be encouraged to bring tools with them. So one organisation, the one that really had the fabulous, everywhere's had great results, but the best, they brought their skin bundle and that they devised, and now that's something that's being spread across the whole of the country, and that came from this learning cafe. And they bring storyboards where they track the journey and they show their measurement and their stories. So I think it's that kind of interactivity. It's not just stand and deliver presentations. It's more about having opportunity to talk.
So you're the facilitator.
Yes, absolutely.
That's it, being the facilitator.
Yes.
Okay, thank you.
Thank you.
May I just add, if you want, I share also my experience because we have the same problem. So two different stories. One is that I learned from my friend, from Carol Porter from Mount Sinai, that they ran a research asking every single person what they value their value were. And I could not do this because one important thing, in my opinion, is to know very well your own context. So in my context, it would be better to start with the formal instrument. So we use an instrument to ask people what their value were and what their priority were. So what a written list of values, and they could choose the priorities and the ones they didn't fill in. This was one, and in the end, to share the result. That was the opening the door. Another experience I also have is to, and I believe very much in this, is to provide also a questionnaire we developed assessing the safety culture. But of course, we couldn't use already prepared questionnaire because of the context. We couldn't ask some question to our people at the present time. So we established this questionnaire. And at the end, we put the team together to discuss the result. And it was very interesting because sometimes the leader said, oh, is this our people? Is this us? And this was very interesting. But also the people really seeing this started to talk each other. And also to the student using this time collecting the stories and then sharing the stories they have collected in the world from patient and from personnel. So the important thing is to open the door and to better understand, but please be really focus on the context because this is the key point. Any other experience, question, or idea to share? Yes, please.
Thank you. My name is Leslie Holdsworth. I'm from Scotland, and I would very much agree with all of the points from our own experience. And I think the key thing is there is not one method. You need to have a whole box full of tricks. But the point I wanted to raise, which I thought was really interesting, was the fact that, I think it was Liz was talking about, you'd ask people to sign up and to pledge. And that, to me, is the one thing I've heard that's been very different today from our own experience, and I'll go away and think about this. Because to me, often what we do is you can get people together, we've never had a problem with people sharing. You can set up communication networks, there are various approaches that definitely do work. But what I liked about the concept of that is my own experience is often frontline clinicians don't feel they have the permission. And that's what I liked about the idea of having something where they make a formal pledge. It can be based on their values and the other issues that drives them personally. But if they have the mandate then that somebody is saying, yes, we want you to take this forward, and that they're actually pledging and signing up to something, I would think that just looking through the concepts, that the issue of ownership is much more tangible. So thank you very much for that little tip, and I'll take that away and think about the Scottish context of that.
I think what's really interesting is that we had a web-based pledge. So we had a rolling on-call. So people's names were there. So once they'd pledged, you saw your name amongst everybody else. And that we had we still got on the Institute website, you've got a counter. So every time somebody new pledges to I am committed, that counter goes up. So you can really see, once you've clicked that button, you can see you're having an instant impact, and you're collectively with thousands of other people. So it is a very powerful tool.
Okay, here.
My name's Debbie Janaway. I'm from England. I just wanted to back Liz up, really. I was one of the, in East Kent, we were one of the case studies around high impact action preventing falls and staying safe. And the point that I really wanted to make was that I agree that nurses are a very powerful body, and that it's absolutely crucial to motivate and mobilise leaders at ward level. And the most important thing for nurses is for them to understand the benefit that their improvements has on the patient experience. And once they realise that, then it's a really powerful tool for them to sustain their improvements and really develop pride in them.
Can I share it? I think, as one of fellows mentioned, that there are a number of things involved in motivating others to share, or motivating those who are involved to share. I will tell you a very brief story. In one of the provinces where we work, we are working with a certain number of health facilities, for instance, 5 health facilities out of 35, which is run by an NGO. And one day the provincial coordinator came to me and said that, Mirwais, look, the facilities where we are implementing changes, those changes are already taken by the other health facilities, and they are implementing it at the same time. After a year or 2 years, if the Ministry of Public Health comes and asks that, where did you work? And we will say, in these 5 health facilities. And then they compare the 2 health facilities, they would not find any difference in these 2 type of health facilities, because both of them implemented the same kind of change. I think that particularly gives us in Afghanistan a lesson that when peers see that their fellows are involved in a process and they are making improvement, they are making their progress, then they also try to own that thing, and they are also trying to implement that. And back to the question that I was asked before, I think one of the other biggest motivator for this improvement has been the involvement of those who are, in fact, the frontliners. They are involved in the identification of change idea. They are involved in the assessment. They are involved in every single step that gives them the opportunity to express their ideas, and then they daily see that their ideas are implemented, and they own that work, and then they get motivated to move forward.
Any other questions? Yes, one last question here in the front, please. And share your experience too, please.
Thank you. My name is Harry Morendijk. I'm a physician from the Netherlands. And my experience is that everybody likes to innovate, but nobody likes to change. And saying that, there are a lot of titles out there on leadership, and everybody wants to be a leader. But if it's with regard to nurses and also a lot of physicians, a lot of us are just followers. Now, there's a great book out by Barbara Kellerman called Followership. So I encourage you all to go read that and to learn more about the vast majority of workers that are mostly followers, and only some of them are leaders. And if we better understand why people follow, then we don't have to share new ideas. Let's just start sharing the ideas that are already out there because they are already good enough at this point in time. That's my statement.
Thank you very much. Any last question? No. So thank you very much for attending. Thank you very much for sharing. Please continue to share. And thank you very much to our speakers. Thank you very much. Thank you. Thank you very much. Thank you. Thank you. So I want to, by the way, I want one of these, by the way.
Yes, get one of them. Definitely.